This is the second and final voiceover for early childhood. I'm Molly Lombardi, and if you need anything, feel free to reach out to me. Now that we've gone over the growth and development for early childhood and looked at age group challenges, we're going to apply that information and talk about nursing assessment, safety, and pain. For the nursing assessment part of this lecture, we're going to start off by discussing a health history and how it's different for a toddler or a preschooler. The physical assessment, again, height, weight, vital signs, age-specific variations, and then how an early childhood assessment is going to differ from an adult assessment. For the health history, it's much like a health history for an adult patient. Of course, a lot of the information is going to be coming from the parent themselves rather than the child. And you can certainly use the child and should include the child in it, but most of the hard information is coming from the parent or caregiver. So it is composed of course, the chief complaint, what sent them in, their family history, any pertinent information there, their medical history, and this is specific to this age group because you're focusing on immunizations that they've had or that they need, any vision, hearing, or developmental screens and how they were. So make sure we look at the immunization schedule that I've highlighted in Appendix B, and I've also included as a printout in Blackboard. You're going to want to print this out and bring it to lecture with us. Any medications the child may be on, any allergies, either food, environmental, or medications, and then review of systems, so paying special attention to how the toddler or preschooler is eating, sleeping, and how their elimination is going, because again, think about the developmental milestones that they're going through for this age. That's why it's really important to pay attention to that. And then social history, so their family composition, so think back to the family lecture, how they're functioning, and what's the composition of it. And then also any child care that they may have and situation of that. And then their behavior concerns. So remember that they're going through defiance and tantrums and starting to develop into more obedient people. So it's important for the nurse to spend some time about talking their social history. The physical assessment will start off with the height and weight. It is important to note that young toddlers should be measured, so get their height while they're laying down. And this is due to a really common curving inward of the lower back that is present when they're in a standing position. You can calculate their BMI and see where they fall on their graph. There's also a CDC Growth Chart. That's Appendix D of your textbook. Please look at that and bring it. Again, it's another printout too on Blackboard. We're going to be doing it during class. We're going to be plotting on the CDC Growth Chart. This is really important. It's any one bit of data is not as important as a group of data. So the growth chart shows you where they are according to their age for height and weight and where they fall in percentage. So if you have a toddler who's in the 3rd percentile for height, then you know that they are shorter than most in that age group. Where if you have someone in the 95th percentile, they are taller than 95% of people in that age group. So it gives us a lot of information when we look at it as a whole, because remember they fluctuate in how they're growing, and this gives a bigger picture as if there's a sudden drop or sudden increase, then it should be looked at further. Head circumference is also measured for anyone under the age of 2, and this gives us information about bone growth and also developmental growth. Vital signs are obtained, and vital signs have different parameters than adults do. So you'll see the chart here. I took it from your textbook. You'll see that the pulse, respiratory rate, and systolic and diastolic blood pressures vary. You don't need to know the exact amount, but you do need to have a pretty good understanding of it and understand that smaller people have smaller blood pressures and higher pulse. Also know that the height, weight, and gender is also going to influence blood pressure reading. The physical assessment for a toddler is pretty similar to that of an adult with a few variations that your textbook highlighted in both your textbook and ATI that I've incorporated here. It's important to note that for the most part you want to try to do a head-to-toe assessment. However, you need to do it from the least to most intrusive or invasive or painful. So start off with the least scary thing. And if you can follow a head to toe, that's fine. But you don't want to look into their mouth as the first thing that you do because that's a little bit scary usually for children. You want to aim for their cooperation. So that's why you're saving for the intrusive or painful things to go last, because you don't want to have them scared of you right off the bat. You want to try to get as much as you can done and save like the immunizations for the last thing. Developmental assessment you can be doing and should be. In clinical, we usually do the Denver developmental screen on our clients there, so you'll get familiar with that. This is a way to see, again, because everyone meets their milestones at a different rate and pace, to see if they're on track or if maybe they're falling behind to the point where they'll need early intervention and have special services to catch them up to where they could be or should be, or at least enhance. And then there's also a key note here to adapt what you're doing based on their developmental age. What I mean is, and this is going to make sense when you go to clinical, when you have a 10-year-old child, their age might be 10 years, but their development might be 5 years. And you want to treat them and talk to them and interact with them as a 5-year-old, not as a 10-year-old. Anything that you're doing, even if they're developmentally appropriate, it should be on their developmental age. So your textbook has an example when you're auscultating the lungs. You're not going to be able to say to a child, a toddler especially, take a deep breath for me. One, they don't understand what that means, and two, they don't have any incentive to do it. Instead, you can say, pretend like your finger is a candle on a birthday cake and tell them to blow out the birthday candles. This gets them to take that deep breath, and they want to do this because that's fun, imaginative play. It's based on their developmental age. Same thing if you have a post-operative client who is of early childhood and they need to use an incentive spirometry. Chances are they're not going to use it because it's not very fun and exciting. Instead, you can have them do activities like blowing bubbles or blowing on a pinwheel. It works much better than having them try to use an incentive spirometer. So the actual physical assessment itself, the different things for early childhood than adult is that they have a larger head to body ratio. So their heads are very large compared to their body. And I'll we're going to start off lecture. I'll show you a picture of displaying that. Their anterior fontanelles, posterior should be completely closed, and the anterior usually closes between 12 to 18 months. So by 24 months, it should be completely all closed. They have a larger body surface to weight, and that's important too when we're talking about burns. They have a larger surface area. Their tongues are larger, and also the soft tissue around and in their airway is larger. So you can imagine that can cause a problem with small airway with all this soft tissue. So when they have respiratory illness, it's a little bit more severe. They also have shorter and more narrow airway, and it's also more elastic and collapsible. So again, more problems when we have a viral illness of respiratory tract. Their chest is more flexible. They have weaker abdominal muscles, so they have that pot belly appearance usually. Oftentimes they're belly breathers, which can sometimes get mistaken for a sign of respiratory distress. So with this age group respiratory distress, we will see the retraction, so the sucking in between. So if it's intercostal, you'll see it in between the rib cage. You can also see substernal. You can see it in a variety of ways. Another sign of respiratory distress is nasal flaring, so their nares opening and closing. Sometimes head bobbing you'll see, so the head's going to bob up and down as they're working to breathe. A common finding is bow-legged or knock-knees appearance, and this is common, and it usually dissipates as they continue to grow. As long as their feet are forward, they're good, typically. They have a high metabolic rate. We discussed this earlier, so while they won't show as much extra fat than we would if we eat that way, it'll still catch up, and they should have healthy eating habits. Even though they do have this high metabolic rate, and it's good for them to be eating, 6-7 times a day. They also have a high fluid demand. They have little reserve for fluid. So when a infant or toddler has a GI bug, say they have rotavirus, sometimes that leads them in the hospital because they don't have that fluid reserve, and they still have that high demand, and they'll just need IV fluids. They also have a total blood volume that's higher than that of an adult. Now we're moving on to a huge priority here with early childhood and really pediatric nursing in general, and that's safety. So we're going to talk about nursing interventions and then also safety education for caregivers. Safety is a priority for every age group. The reason why it's more important for this age group is because it is the #1 unintentional cause of death in the U.S. for all children. And this is according to the CDC, their 2015 release. For ages 1 through 4, the mortality is usually from the first one being drowning, and then the next most common is motor vehicle accidents, followed by homicide, suffocations, and then either burns or fire. And then the, again, same age group of 1 to 4, the non-fatal injuries, severe injuries, are led by falls, and then either struck by or against objects, bites and stings, and also poisoning. Our nursing interventions are going to be aimed at minimizing or decreasing these risks, so the most harmful that we just went over on the previous slide. For the inpatient setting, so when they're in the hospital, it is important for the nurse to minimize fall risks. And this is extremely hard for this age group to begin with because they have poor motor control still, but especially because the cribs that are used in the hospital are high up and they have the drop down side rails. It is a priority for the patient to be in an age-appropriate crib, so anyone under 2 has to be in a crib, and they also have a top to them so they can't climb over it. But sometimes what will happen is the side rails that drop down will be left open, and the child will fall out of the crib, and it's about a 3 or 4 foot fall that they have from the crib and setting. It's important then to also educate the caregivers how to minimize the risks when keeping, all 4 side rails up for the crib when a parent isn't right there in arm's reach. Other important things to go by is to keep equipment out of the crib or bed and to keep it untangled. So I'm talking about oxygen tubing. If it's not being used, it shouldn't be on the crib or bed. Any wires or tubing that they do have, so if they're on an EKG monitor or if they are hooked up to an IV, making sure that it's untangled and it's not excessively long, that they can get tangled in at nighttime and strangle. For night, they should have some kind of dim lighting, safety lighting in the hospital setting. Sometimes it'll be too bright, parents will say, and they'll try to cover it up. But obviously, being a change in environment for the child, if they get up out of bed at night, you want to have some lighting for safety. Hand sanitizer should be kept out of reach. It's full of alcohol, so if children get it and consume it, they can have alcohol poisoning from that. And then explore any potential CPS needs. And what we mean by this is if there are some red flags about abuse or neglect, a nurse should explore it a little bit to see if there is a reasonable doubt to believe that there's any abuse or neglect going on, and then to hotline CPS if there is any suspicion. It's not the nurse's job to be the one to really look into it and investigate it, but just to have enough to believe it could happen. CPS is not punitive. It is used to make sure that the children are safe and to also set families up with the appropriate resources and avenues to help them stay safe and healthy. In the home setting, you'll see the home setting took up more than the inpatient setting. There are dangers everywhere you turn. And a lot of the home setting too can also be applied inpatient. So this is when the nurse is going to provide guidance to the family to keep a safe environment. And if it's a home health nurse, they'll be doing a home health survey to make sure that these settings are safe. So the first thing we have here is hot liquids. So like things like hot coffee, making sure that they have a lid on it and are kept away from children. Making sure that it can't be if it's on an end side table, that the toddler doesn't pull on the table and then dump the hot coffee on themselves, leading to a burn. Keeping them away from stoves and fireplaces as well. You want to cook, or at least tell parents to cook on the back burners with the handles of the pots turned away, so they're not hanging over, so they don't reach up. Because remember, at this developmental stage, they're grabbing on certain things in the toddler. You don't want them to grab the pot and have the hot whatever's on the stove fall on them. And if there's a stove with the knobs or the handles in the front, they can be taken off and stored on the top of the counter where they can't reach, so they can't turn the stove on accidentally. Water temperature should be at or below 120 degrees Fahrenheit. In addition to this, any food or drinks that are cooked or warmed should be checked before serving, especially in the microwave where they'll have hot pockets. You shouldn't have any microwaved formula or baby food because of this. Medication should be kept away in a locked cabinet or a locked box up ahead. Same thing with any poisonous chemicals or cleaning materials. And it's also important to have the family have the poison control number in the house easily accessible. And any rooms that are not childproof should be locked, including the bathroom. It should be they shouldn't be able to go in it whenever they would like, because the toilet is extremely dangerous and the child can actually fall in the toilet and drown. Continuing on the other side of the screen, we have safety gates, and I included installed properly, making sure that it is, if it's at the top of the stairs, screwed into and secured to the wall so they don't climb on it and fall down the stairs with the gate. Secure any dressers or shelves or any, it used to be popular for the big heavy TVs to be on a stand, making sure that they're screwed into the wall because, again, they're climbing up on furniture and you don't want the heavy piece of furniture to fall down over on the child and crush them. Windows should be closed, especially when you're on any higher floors than this, the first floor, because a child can, they love to run around and they don't have the motor control and they can run right outside a window and fall out. No small toys or parts, so make sure that they're age-appropriate toys. Usually they'll say, be a circle with an X through it with a 0 to 3 on it, meaning that it's not intended for children of small age because they'll put it in their mouth. Making sure to toss broken toys and to have the parents check the recall toy list often. Secure or remove any cords from blinds. So we're talking about the vertical blinds that have the cords that hang down from them. A lot of times they'll get tangled or form a closed circle on it, and they can strangulate in those cords. They're also found on curtains, and sometimes clothing like hoodies are especially dangerous, especially when playing on outdoor play equipment. Appropriate food choices. So grapes are dangerous. We've learned that, especially frozen grapes. If they do eat them, because it is a healthy choice, making sure that they are cut up into multiple sections. And also hot dogs cut the long way. So not so that they're coin shaped, but cut lengthwise. So that way they are not in the same size and diameter as their throat. No nuts, popcorn, or hard candy because of choking. Same thing with choking, no coin money or latex balloons. Close supervision with any animals, even trusted animals, can, if they are, in their face, which they don't, the child doesn't know that they're a danger. If they're too close to it or hurt them, it's an animal instinct to snip. So making sure that they are really supervised closely. Never leave a child in a bathtub or any body of water unsupervised for any amount of time. No toys in the pool, because this can lure the child to try to grab the toy and fall in. Making sure to lock all pool access is important as well. And as far as safety when walking outside with cars and in parking lots, making sure an adult is there holding a hand. And if they're outside playing on their bicycles or scooters or skateboards, making sure that they're wearing their helmets. Another safety concern is car seats, making sure that the child is in the age-appropriate and really size-appropriate car seat. This is Appendix C of your textbook. You'll see that birth to age 2 is rear-facing, so part of toddlerhood should still be in a rear-facing car seat until they reach the proper weight and height limit of the seat. And then they can switch around age 2 and continuing till at least age 5. So all of preschool age should be in a forward-facing car seat. And this usually has the 5-point harness restraint, which we've seen on social media so many times has really been a great push to make sure that everyone is well informed of where the clip should go for proper safety. And it's right by the armpits, and we'll talk about this a little bit more in lecture. Booster seat is allowed for children at 5 as long as they are the right height and weight for the booster seat. The final section of this voiceover is pain, and this is going to include a pain assessment and different pain scales that we can utilize. The reason why pain is an appropriate category to talk about when we're discussing early childhood is because developmentally, remember, their language is not where an adult is, and it's hard for them to communicate and get their point across. So especially when we're talking about pain assessment, adults, we just ask them for a number and they cognitively understand it and linguistically can verbalize what they need, where that's not the case for early childhood. So that's why it can often be challenging for a pediatric nurse to assess and reassess pain in their patients. You also should be evaluating a cause of pain. So understanding if they should be in any pain will be a clue as to how severe it should be, although there's no typical amount of pain for any given reason. You can assess with the use of vital signs to give you some objective information. So usually with pain, you'll see an increase in heart rate and blood pressure and also respiratory rate. So that'll give a clue to the caretaker that there's pain going on. You'll pay attention to facial expressions, so grimacing, whimpering, frowning. That'll be a clue that there's pain. Any movement, so guarding or curled up into a ball or sudden standing up really straight and stiff suddenly, those are usually signs of pain. And also vocalization, so either lack of vocalization, sometimes they become stoic and quiet, or they're screaming and shrilling in pain. Parents play such an important role in pain assessment. They know their child and they can understand a little bit more, not a little bit more, a lot more than we can as nurses. We're only seeing them for such a short amount of time. So the parents are a great resource when evaluating and reevaluating pain and the effectiveness of our interventions. Medical play is what your textbook calls. It's also called therapeutic play, and this allows the child to explore medical conditions or procedures, and it gives them time to express themselves and their fears and any needs that they might have. So this is when, let's say, a child is going for an appendectomy in a very friendly way, age-appropriate way, without scaring them too much. Usually a child life specialist or the bedside nurse, if they're skilled enough, can explain the procedure to them and usually do it in a way that is not as scary and can be done with a stuffed animal or a model. A lot of hospitals have model patients that they give their children and explain procedures on. And they'll also give them IVs or, Band-Aids where the child is expected to have a Band-Aid or a dressing. And that's a form of therapeutic or medical play. This can also be used when evaluating pain. So you can have the child show either on their own body, and if sometimes they won't do this, it's easier for them to do it on the play doll's body, show what's going on for them, or show them how bad it hurts by hurting the actual mannequin itself. And also keep up on comfort measures. These are very easy to do and often, unfortunately, overlooked, but they go a great way for this population. And that includes letting them have their stuffies, so their little stuffed animals, whatever they're comfortable with. A lot of times this age group is attached to a certain object. Sometimes it's the stuffed animal, their little blankies, a little blanket that they keep with them all the time, or soothies. So maybe it's a pacifier or, you know, a little item that they keep with them. And this is, as long as it's appropriate medically, should be kept with the child as much as possible. Some pain scales are used in the hospital setting, and it really depends on the hospital, what they typically use, and also the age setting that they will have as their patient population. I've included two of the most frequent used pain scales here on the slide, and that's the Wong-Baker Faces pain rating scale. You can see on the first image it has the faces going from smiling with 0, no hurt, all the way up to 10, hurts a whole lot. And usually what will happen is the nurse or caretaker will explain the different pain ratings and read it out loud to them. So say 2 hurts a little, 4 hurts a little worse, and they'll point to it as they're explaining it. And then this allows the child to point to a picture, or they will give a number if they're a little bit older, so in the older preschool age, and they will use this throughout. A lot of hospitals will have it on the back of the nurse's badge, or they have them in each room for the child to point to and to help keep that communication. Because remember, think about the toddler who was reading the book, or he wasn't really reading, he was pointing to objects. They understand a lot more than they can say, so this gives them an area for them to point to and communicate. The Flac pain scale is a little bit different. It goes through, you can see it goes 1 through 5 and 0 to 2, and this allows the nurse or the caretaker to look at the different areas on the left, so either the face, leg, activity, cry, or consolability, and then score them on the right-hand side. Either their face, there's no particular expression or smile, is 0. There's an occasional grimace, frown, withdrawn, or distressed in 1, so they'll get a score of 1. And then 2, which would be even worse, that it's frequent frowning, clenched jaw, quivering. So those are all stronger signs that there's pain going on, so they would get a higher score. So the higher score, the more pain. It's just a different way to assess and reassess children. That concludes the voiceovers for early childhood. I thank you for staying with me so long. And also, if you have questions, you know you can always reach me. I prefer you email me before we have lecture. That way I can address group needs in that setting. Thank you.